everyone. I see a lot of new faces, and you probably are not used to seeing me. I'm Suzanne Johnson. I'm the Deputy Director here at the Prevention Research Center for Healthy Neighborhoods. I want to welcome all of you to our monthly research seminar series. It's always on the second Wednesday of the month and at noon, except we take a hiatus in August. There will be one more seminar on July 10th, so please try to join us for that last one. We'll have our schedule for the next year coming out soon, and it will be on our website. And if you're on our mailing list, you'll also get a copy of it. If you haven't signed in, please make sure that you do so before you leave. Also, if you do any social media, you can use hashtag PRCHN seminar for your live tweets during the seminar. It's a pleasure to welcome one of our affiliated faculty and her team today. Siran Koroukian, PhD, is a health services researcher and associate professor in the Department of Population and Quantitative Health Sciences. Also leads the Population Cancer Analytics Shared Resource of Case Comprehensive Cancer Center. Today you'll hear from her and Uriel Kim, who is an MD PhD candidate here at CASE, and Weichuan Dong, who is also a PhD candidate at Kent State. All right. I'm going to let Siran tell you more about her study, and she'll tell you about asking questions and how the process will go today.
Good afternoon, everyone. It's really a pleasure to be here, and thank you, Suzanne, for the introduction and the opportunity to present. I should preface this presentation by saying that Johnny Rose, who is the engine behind this project and who's the PI on this project, could not be here today, and so we volunteered to present on his behalf. But this is really his project, and we're going to present today on building a cancer data resource or infrastructure to advance disparities research, community health, and advocacy efforts. So no conflicts of interest to disclose, but a lot of people to acknowledge. We have, so I told you about Johnny Rose, but also a whole bunch of people from PQHS and otherwise. We have Dr. Jackie Curtis, who just joined our faculty at PQHS, Weichuan Dong, who was just introduced, Joe Neff, who just joined our team, Becky Carnes, who is from Cuyahoga Community Board of Health, Uriel Kim, whom you'll hear from shortly, and Abby Statler from the Cleveland Clinic. And I would really like to acknowledge the Institute for Computational Biology, represented today here by Wanda Latimore. Wanda and her team have been very instrumental in really building the infrastructure, but also developing an interactive platform to be explored with NeoCase, the data infrastructure that we'll talk about, and people from UTech and the Secure Research Environment for their support and for all the work to be done in that environment. And here are our funding sources, to which we are very grateful. And I'm going to turn it over to Uriel to do a big chunk of the presentation, and then Weichuan Dong, and then I'll pick up from there again.
So thank you again for the opportunity to present. The PRC seminar series is definitely one of my favorite seminar series on campus, and it's not just for the food, but I think the audience in general is really receptive, and this is just a great academic community here, so it's definitely a pleasure to present. So today we're going to cover the development and implementation of NeoCase, which stands for the Northeast Ohio Cancer Risk Assessment and Surveillance Engine. And NeoCase is a multi-level data infrastructure that combines both individual level data and contextual level data. After that, we'll talk about the interface of NeoCase, which is how most users will actually access the data within NeoCase. And then we'll end with a couple of studies which use NeoCase data, which I think is a really great illustration about how useful this data infrastructure will be and how versatile it is in general.
Uriel, can I interrupt for a second?
Yes.
Let's make this an interactive session, so please just tell us what's crossing your mind and any questions that come to mind, because NeoCase is in a phase of development, and it's constantly evolving, and your thoughts will be very helpful in knowing where to go from here and what else we can incorporate in it to make it more useful to you guys, because you all will be the users of NeoCase.
Yeah, definitely. If you have any questions, stop me at any time. I usually go on a roll, so if I don't catch your hand up, just wave it pretty vigorously, and I'll be happy to answer your question. So first, I think it's useful to talk about the origins of cancer disparities in general, because it'll really frame our discussion. So when we think about cancer disparities, one factor that contributes to cancer disparities is an increase in incidence across different subpopulations. And this is really well documented, right? Across racial subpopulations, around ethnic subpopulations, across socioeconomic subpopulations, we see a difference in incidence. So for example, for colorectal cancer, we see that in non-Hispanic whites, the incidence rate is 20% lower than for African Americans. A second contributor to cancer disparities in general is later diagnosis. And a mechanism through which this might occur is a lot of the most common cancers, so lung cancer, breast cancer, colorectal cancer. Those are cancers that are amenable to screening. But across different subpopulations, the uptake for screening differs. So again, for colorectal cancer screening, across educational subpopulations, we see differences in screening rates. So for those who are eligible for screening and have a college education or higher, the screening rate is around 70%. But those without a high school education, that rate drops down to 47%. Another contributor to cancer disparities is poorer stage-specific survival. So what that means is for a given stage of cancer, survival outcomes differ across different subpopulations. And a mechanism through which this might have occurred is the gains that we see in clinical advancements and technological advancements have really been distributed unequally across different subpopulations. So again, for colorectal cancer, between 1975 and 2008, mortality for distant stage colorectal cancer has decreased in the non-Hispanic white population by 30%, but for the African American population, we only see a decrease of about 5%. So all of these contributors lead to greater mortality across different subpopulations or cancer disparities. And when we think about the underlying causes of those contributors to cancer disparities, that's when we get to fully appreciate the complexity behind cancer disparities. So for the differences in cancer diagnosis, treatment, and survivorship we know that factors like race, ethnicity, education, income, access to transportation, all of those factors work together and work interconnectedly to kind of predict those outcomes. And when we take one step back and think about cancer incidence in general, we know that it's a complex interweaving of environmental factors, genetic factors, and behavioral and social cultural factors. So when you look at this conceptual model and all of its complexity, it's really useful to think about place, because place really acts at all levels of this conceptual model. So place being your location, your community, and where your life is lived is really predictive and associated and really influential when we think about cancer disparities. Because place predicates your access to different structural resources, whether it be access to healthcare or to schools, and it also influences different health promotion activities and behaviors, right? Your sense of safety is predicated on where you live. Your access to green space, your access to healthy, nutritious food, all of that is related into place, and that's really where our framework is derived from. So that brings us to NeoCase, again, which is a multi-level data infrastructure which combines both individual and contextual level data. And what's really innovative about NeoCase is that it allows for place-oriented investigation of cancer disparities by providing both information about cancer and also related contextual factors at a very, very high geographic resolution. And this is in contrast to other data resources that we have for cancer and cancer disparities, which are typically siloed and only look at one facet of cancer in general. And that really hinders your ability to take this place-oriented perspective. So our ultimate goal for this data infrastructure is to allow for researchers and public health officials and community advocates to really identify the locations and populations with a disparate burden of cancer. And after identifying those populations and communities, to begin to start to understand the factors and the variables that go into predicting those cancer disparities. And then by taking that really specific place-oriented perspective, we can design interventions that are both responsive to the different subpopulations and responsive to the community in general. Eventually, because we have existing data use agreements with all of our providers of this data, we hope to update NeoCase regularly, and that'll allow investigators and others to evaluate the impact of interventions which are delivered to the communities, and also to study the dissemination of different clinical practices and screening practices. So again, NeoCase has a lot of data sources that we're integrating, and we can roughly divide those data sources into individual level data and contextual level data. So at the core of our data infrastructure is the OCIS, which is an individual level data source. And the OCIS stands for the Ohio Cancer Incident Surveillance System. It's administered by the Ohio Department of Health. And all incident cases of cancer in the state of Ohio are required by law to be reported to the OCIS. So we get really good coverage of cancer statistics within our state. And in addition to providing those cancer statistics, there are a lot of other kind of individual variables that are captured within the OCIS, and they include demographic characteristics, tumor characteristics, including the histology. Yes, question?
Just out of curiosity, do you know if other states track cancer data like this too?
Yeah, so each state has their own registry. So the OCIS is Ohio's, and it uses a really standardized format of collecting data called the NACER format. Great question. So the OCIS includes a lot of other rich individual level data, including occupational family history of cancer and insurance type. Oops. The second source of individual level data that we have is from the death certificates. This again is provided by the state of Ohio, and it provides us with an authoritative date of death. We're able to link together the OCIS and the death certificates using an algorithm which uses social security number, name of the patient, and date of birth to link together their death certificates and the OCIS, and that gives us a really precise estimate of different survival statistics as they relate to cancer. Now, for our contextual level data, we have information on where mammogram facilities are located in the state of Ohio. We have information on where different cancer care facilities are located and whether or not they include different modalities of cancer treatment, whether they be chemotherapy or radiation oncology. We have data sets from the Health Resources Services Administration, including data on health professional shortage areas. So this is information about provider density and the ratio of providers to the overall population in a given community. Another data set we have from the HRSA is the Area Health Resource File, which gives us information about hospital utilization and expenditures. We have another data set from the Ohio Department of Health called the OMAS, or the Ohio Medicaid Assessment Survey. This is a very rich data source that covers information on access to care, health status, occupational health, and this is for the entire adult population for Ohio, not just the Medicaid population. And finally, we have data from the U.S. Census, which captures a number of constructs, including population characteristics, employment characteristics, income, and poverty. Yes, Suzanne?
In the death certificate, does the official cause of death have any impact on what data you use?
Yeah, so that is notated, but we can actually identify our cancer patients by linking them to the death certificate, so we can isolate just the patients that had cancer within that.
But what if they didn't die from cancer?
Yes, so that's an important distinction. So we can measure all-cause mortality and then cancer-specific mortality.
The underlying cause of death is recorded.
Okay.
Great question. So now we have this individual level data and this contextual level data, but they're different units of analysis, so we have to find a way to link them together. So for our contextual level data, we can sort those data into two broad categories. We have point data, and then we have data that relates to a specific geography. So we have two sources. We have two sources of point contextual data, which are the mammogram facilities and the cancer care facilities. And we're able to link that up with the individual level data that we get from the OCUS using distance, because we have the address at diagnosis, so we can calculate out the distance between a patient and a particular mammogram facility or a patient and a particular cancer care facility. Now, for these other data, which relate to a specific geography, again, we use the address that the patient had at diagnosis to find a common geographic unit of analysis. And that can be the block group, which is a very, very fine unit of geographic analysis, census tract, zip code, municipality, or county. So within the NEO case, what we've done is we've integrated all of these individual sources of data and all of these contextual sources of data. And what we can do next is we can keep those individual level records. And this is really important or useful from a research perspective to give us that granularity that we need. But it's also important from the sense of scaling NeoCase, because then we can add in a lot of other interesting individual level sources of data, whether it be claims data or data from the EHR. Or what we can do is we can aggregate up those individual level records to a common geography, whether that be zip code or zip code or census tract or county or state or something like that. And this aggregated data is what's available through our user interface. So that brings me to the next part of our presentation, where we'll walk through the interface. And again, this is how most people will access our data that's contained within NeoCase. So when we were developing this interface, there are a lot of examples, both nationally, regionally, and at the state level. We really wanted to be very thorough about examining all of these existing interfaces to make sure that our interface was as useful to the end user as possible. And what we learned from looking at these other interfaces is that it's really important for our users to be able to run very, very highly customized queries. For example, it might be of interest to look at lung cancer incidence by zip code in Cuyahoga, by race, by income level, by education. And that kind of query is not something that's typically available in these other interfaces. It's really also important, again, because we are working from this place-oriented perspective to include a lot of contextual level data. And that's where, again, NeoCase is different than other existing interfaces. We also think it's important to be able to map and visualize the data that's generated within these queries in NeoCase, because I think most people are visual learners, and even if you're not, it's, I think, just easier to digest data when it's visualized rather than just looking at a table. And finally, it's really important, again, because we have that place-oriented lens, to be able to look at all of this data using a very high geographic resolution. And again, that's a really important element of our data infrastructure. So I'm going to walk through some of the geographies that are available within NeoCase, and I think it'll really illustrate how useful having this high-resolution geographic perspective is. So this is surprise, surprise, for those of you who don't know, the state of Ohio, the great Buckeye State. And this is where a lot of those national data infrastructures stop, right? They provide information on a state-by-state level. But we know from experience that Ohio is a very heterogeneous state, so it's useful to go one level deeper. So if you go one level deeper, you go to the county level, and this is where most other regional interfaces stop. In Ohio, there are 88 counties, but again, if we just draw from our personal experience, we know that within Cuyahoga County, from one edge to the other, it's a very heterogeneous region. So if you're trying to take a kind of place-based approach or a place-oriented approach, even looking at the county level isn't quite fine enough in most instances. So we can go one level deeper to the zip code. So there are 1,198 zip codes in Ohio. I counted them all. So again, that provides a much finer resolution, which is really useful for place-oriented studies. And then we can also look at municipalities. So perhaps you're interested in looking at different statistics for cancer in Cleveland versus East Cleveland versus Shaker Heights versus Parma or something like that. So this is a level of a geography that you would want to use for that kind of analysis. And then finally, we have Census Tract, which is our finest unit of analysis within our interface. And just to give you an idea of how finally resolve these census tracts are. This is kind of a map of where we're sitting right now. So let's see here, laser pointer. So we're eating lunch right here. So the campus of Case Western is encapsulated within one census tract. We have Little Italy over here in one census tract. And then the top of the hill is broken up into many census tracts. So this is a very, very fine unit of analysis. So now I want to show you what the interface actually looks like. And again, we're in, this is kind of at the beta stage, which is why, like Siran said, we really want all of your feedback because we want to make this interface as user-friendly and as useful as possible. But this is how it looks in its current iteration. So you go into the interface, and this is what you're greeted with. And the first question it asks you is how you want to group your data. So let me see if I can press play here. So the first question, again, it asks is how you want to group the data. So you can choose county, zip code, municipality, and eventually we'll build in that census tract capability. Then the next section of the interface asks how you want to filter your data. So you can filter by date range. We have 10 years of OCUS data in our interface right now. So from 2006 to 2015. You can filter by ethnicity. You can also filter by whether or not individuals live in rural or urban counties. You can filter by primary site, so maybe you're interested in looking at just breast cancer or just colorectal cancer, or you could be interested in looking at all cancers generally, and that's how you would execute that criteria. You can scroll down a little bit and you can filter by county. Maybe you're interested in just looking at Northeast Ohio or just Cuyahoga County or the entire state, and that's how you would execute, that's how you would filter that search. You can also filter by SEER summary stage, which is a measure of how far along a cancer is or how advanced cancer is. You can filter by age at diagnosis. Maybe you're interested in just looking at adolescent and young adult cancers. Maybe you're looking at adult cancers in general. So that's the filter criteria you would apply. You can also filter by tumor behavior, so whether a tumor is benign, whether it's in situ, whether it's malignant. You can filter by sex, and this can be useful for sex-specific cancers like prostate cancer or breast cancer. You can filter by vital status, and then finally you can filter by race. Yes?
Are these can you select multiple?
You can select multiple criteria. And again, we really want people to be able to examine data in a high-dimensional way, so we built in a lot of flexibility to allow those high-dimensional queries. Yes?
I have the exact same question.
Exact same question. Excellent. So now I'm going to run a sample query. So perhaps you're interested in looking at lung cancer cases within Cuyahoga County by zip code. This is how straightforward running this query would be. And for the purposes of this demonstration, I'm adding a couple extra filter criteria just to make sure that we don't have small cell counts. So just keep that in mind. So again, the query we want to run is incident cases of lung cancer in Cuyahoga County by zip code, and this is how you would run it. So first, for the grouping variable, you choose zip code. Then for the date range, I think we're interested in looking at all 10 years of data we have. I'm just applying a couple of ethnicity criteria just so we don't have any small cell counts. Not particularly interested in rurality and urbanicity for this query. For primary site, we did lung cancer. For county, just Cuyahoga County, so I selected that. For SEER summary stage, I'm just leaving that blank. For age at diagnosis, I'm putting in a couple of age ranges which capture the majority of lung cancer cases. For tumor behavior, I chose malignant. For sex, I left that blank. For vital status, I left that blank. For race, I'm just adding a couple of race categories to, again, avoid those small cell counts. And then what you do is you scroll down. You can verify that you've entered your query incorrectly. You click Generate Table, and that creates the table down within the window. You also have the opportunity to download the table as a CSV file. And that might be easier for analysis. But if you just wanted to look at the data within the window, this is what it would look like. So in this table, each row is a zip code in Cuyahoga County. And then the columns represent the different individual level variables and the different contextual level variables. So we have statistics on incidence, we have statistics on different cancer-related outcomes, time to treatment initiation, percentage of advanced stage disease, things like that. And if you keep scrolling to the right, that's when you start to get the additional information on the context, which we think is so important. So you keep scrolling, you get information on the level of poverty in the particular community that the individual lives in, the general family composition of those communities, et cetera, et cetera. So when you're done investigating this table, again, we think it's really important that you have a better way of kind of digesting this data, and that's where we have our visualization capabilities built in. And again, this is a little bit in beta testing still, so we're still struggling to figure out how to best implement this mapping capability, but this is how we envision it would look like. So you navigate over to the Visualize tab. So we ran the query up here, so we click over to Visualize, and what that would present you is with two panes. So one of those panes would be dedicated to the different individual level statistics, and the second pane would be dedicated to the different contextual level statistics. So the query we just ran was for lung cancer cases by zip code in Cuyahoga County. So this is Northeast Ohio. So maybe we're interested in mapping the different age-adjusted incidence rates by zip code in Cuyahoga County. So you would click that bubble, and it would give a map of Cuyahoga County displaying age-adjusted incidence rates by quartile. Sometimes it's informative to look at two kind of cancer outcomes simultaneously. Maybe you want to look at both incidence and the proportion of advanced stage disease, which is a really kind of unique marker of disparities when you both have a high incidence rate in a community and also a high proportion of advanced stage disease. So in that case, you would just click both of the bubbles, and then it would give you this kind of map that cross-tabulates those two statistics. When we do that, we see that two zip codes in particular really stick out for both having a high incidence rate and also a high proportion of advanced stage lung cancer disease. So those zip codes are indicated by the bright red that's also outlined. So maybe then the user wants to kind of look at these two zip codes in greater detail and kind of get an understanding of the kind of community characteristics of these zip codes. So what you would do is you would zoom into those two zip codes. Then you would navigate over to the community factors pane of the mapping window. Then it would provide you with all of the different contextual variables that we have within our interface. I'm only showing 3 for the purposes of clarity. But maybe you want to see, what's the proportion of vacant units within these communities. So you would check this bubble, and there comes a map. So you can see that these zip codes are comprised of areas with a very, very high vacancy unit in terms of the residential housing stock. So this is displayed again in quartiles. So this violet-purple color is the 4th quartile relative to the entire county. So again, these communities are definitely communities that have markers for disadvantage. And maybe you want to investigate another contextual factor. So maybe you navigate down to the proportion of households without a car. You click that bubble, and it would generate this map. And again, by this measure, again, we see that these are very, very disadvantaged communities. A very high proportion of these communities don't have access to a car in their household. So when we were developing this interface, we had a couple of end users in mind. And of course, we want this to be as useful to as many people as possible. So this isn't an exhaustive list, but these are a couple of key instances that we think will be really, really useful in terms of the interface. So definitely, our NeoCase interface can be very useful to inform community advocacy efforts. Again, for most cancer data, most of those data are very siloed. They either focus on individual characteristics or community characteristics, and rarely are those two linked together. So it's really, really difficult when you're trying to organize community advocacy efforts to puddle through the data and to kind of synthesize that data and to kind of analyze that data. So we really think that NeoCase will be useful in that sense. We also think it'll be useful for health systems. So in this context, that's really important, right? Knowing which populations have the highest burden of disease and knowing which communities have the highest burden of disease can be really useful from a sense that they can drive outreach efforts. So we're really hoping to work closely with the Case Comprehensive Cancer Center's community outreach team to help make sure that they're mobilizing and leveraging the resources of this academic institution to make the greatest impact in the community. We also think that this interface can have a lot of utility from kind of a classical public health surveillance perspective. One of our team members is Becky Carnes. She's over at the Cuyahoga County Board of Public Health, and her group publishes the Cuyahoga County Comprehensive Cancer Report every 3 years or so, and this is a really influential document within our region. It gives very, very detailed statistics on cancer incidence rates and different cancer outcome measures within Cuyahoga County. But this is a very, very resource-intensive endeavor that takes many, many years of work to assemble. And because the ability to generate these different cancer statistics is already built in within NeoCase, we really think that our interface can help efforts like the cancer report. They would be able to pump out these reports a little bit faster, and not only that, you'd be able to run these kind of reports for not only Cuyahoga but the entire state at large. So that takes us to the third part of our presentation, where we're going to just showcase a couple of studies that we've done using the individual level data within NeoCase. And we're doing this just to show the versatility of this infrastructure and how it can be used for a lot of different health disparity studies, a lot of different health services studies. And because we even have that geographic component within our database, this data infrastructure can be really useful for more geographically oriented studies. So hopefully these next few slides get you inspired. And if you have any other ideas for really interesting studies you think that could be executed with NeoCase, again, we're all ears. So I'm going to pass it over to Weichuan now so he can share a really interesting study that he's done.
Thank you. I'm going to present one of our studies using the NeoCase individual level data. For the purpose of this study is to detecting the geographic regions where people have delayed time to treatment for breast cancer. So the data using the residential locations of breast cancer patients, and the area we're focusing on is this 15 county catchment area. And the variable we are going to use, of course, is the time to treatment variable. This variable initially are days after the diagnosis, number of days. And we want to discuss how delayed time to treatment is detected. The time to treatment cluster variable is classified into 3 categories: less than 30 days, 30 days to 60 days, and more than 60 days. So people may think that more than 30 days is really not good for the situation, but we want to have more granularity of this study, so we have made make a distribution of that showing the 3 value ranges. So the expected number of cases in the catchment area, so we calculated the average of those cases percentages fall into these 3 categories. The first, less than 30 days, we have a 47% of the cases fall into this category, and the 40.5% and 12.2% in the other 2 categories. And then the first step is to scan any part of the study area to see whether the observed cases N1, N2, and N3 have the distribution compared to these expected cases. So we find regions with high percentage of delayed time to treatment and show that on the map. This is the delayed time to treatment demo that's showing on the map. We click. Here is the 15 county catchment area, and we show that there are 3 significant clusters in the 15 county catchment area, but 3 of them are in the Cuyahoga County, and these 3 clusters have a very high p-values, and we have seen there are more clusters that are not very significant, but I do want to include everything here, so just give you a overall idea. We zoom into this area, the clusters, this one, the center of this one is here. You can see that is the center of this cluster is the Solon area, and this cluster occupies most part of the Cleveland region. and we can show the municipality. And next, we really want to dig into the neighborhood rather than city combined to show the cluster that have more granularity. So we did only for the Cuyahoga County to do the cluster analysis. So we turn on the Cuyahoga County cluster analysis. There is one significant cluster that is in this area. We zoom into that area and turn off this 15 county cluster, and we zoom into this area. We show the municipality and see that this cluster is focusing on eastern part of the Cleveland, next to Shaker Heights, and south to the Case Western Reserve University. Yeah, this is a very disadvantaged area. And this is overlaps much of the zip code Uriel just showed us for the lung cancer with the late stage diagnosis and the incidence rate. And we want to explore more about the demographics underneath these clusters. We have a percentage of family under poverty, and we zoom into these clusters, seeing that there are many parts of the Census Tract having a percentage of family under poverty, low level, that overlaps with our clusters. And we can have another layer showing the smaller cluster, showing the Buckeye. It's very disadvantaged region. And we can also show the percentage of African American population. And this area is right here. All right, that's it.
We're very excited to have Weichuan on the team, and we're very excited about this data infrastructure again because there's that geographic component to it. So we can do really interesting studies, GIS-based studies, and I think that example really illustrates the power of this approach. So I have another research example that illustrates, again, why it's so useful to have this multi-level data infrastructure with a lot of contextual information in addition to a lot of information at the individual level. So this next study that we've implemented is the goal of the study is to identify phenotypes which are associated with delayed treatment in breast cancer. So this is a little bit similar to Weichuan's study in the sense that, again, when you're diagnosed with cancer, the ideal situation is for those patients to move into treatment as fast as possible because there's a lot of studies which associate delayed treatment with poor cancer-related outcomes overall. So if there is a delay in the time to treatment initiation, that's definitely a disparity that we want to address. When we think about the factors which are associated with delayed time to treatment initiation, I think intuitively we know that there's a lot of complexity involved, both at the individual level and at the contextual level. And more than that, it's about the combinations of factors which are associated with the poor outcome and also the intersection of those factors, right? So when you think about it, it's not just about being poor. It's more about being poor and being African American and not having access to a healthcare facility in your area and not having the ability to travel to a hospital or not having the capacity to have someone look after your children while you're receiving treatment. It's really at those intersections where we see these disparities being propagated. And we really wanted to find an approach and a data set that would be able to capture that complexity. When we step back and look at traditional disparities research in general, really the methods that have been used within this field are kind of mismatched for the kind of complexity that we want to capture. So most traditional studies of disparities research use regression-based approaches, and regression-based approaches, while they are powerful, are ill-suited to kind of look at this complexity, especially when we're really interested in looking at the different combinations of risk factors and the intersections of risk factors. So when you think about a regression-based model, you're really asking the question of what is the independent effect of this one risk factor on this particular outcome, where the question we want to ask is what is the effect of this combination of risk factors? Or what is the effect of these intersections, and how do they relate to the outcome? So that's really where this study is getting at. So again, we're really interested in identifying those phenotypes that are associated with the delayed time to treatment initiation. And phenotypes, as we just define them, are the combinations of individual and community level characteristics that signify an increased risk for delayed treatment in breast cancer. And again, I alluded to the fact that regression-based approaches are a little bit ill-suited to answer this question. And that's why we've really looked into more machine learning-based approaches to tackle this question, because machine learning-based approaches are non-parametric, so they're able to really query the full breadth of all of the individual level factors and all of those combinations which might be predictive of disparities. So in this instance, we used an approach called k-medioids clustering, which is pretty analogous to k-means clustering if you're familiar with that approach. But in k-medioids clustering, we're also able to include categorical or qualitative variables in addition to those continuous variables. So these are all the variables that we throw into our k-medioids clustering machine learning algorithm. So we have 7 individual level variables, so age at diagnosis, race, ethnicity, marital status, year of diagnosis, SEER summary stage, insurance status, and then we have a whopping 16 contextual level variables, everything from overall racial ethnic composition of a given community to the percentage of that community that has a bachelor's degree or higher, the vacancy rate, the rurality of a particular community, the average family size. And what we ask the machine learning algorithm to do is to find all of the interesting combinations through which different observations are related. So if you try to attempt to do this using a traditional regression approach, the regression would be gasping for breath. But if you use a machine learning based approach, this is pretty easy for the algorithm. So this is the final output you get from a k-medioids clustering machine learning approach. So basically what we've done is we, again, fed in 23 different individual and contextual level variables. And what we're doing here is we're projecting those 23 variables along a 2-dimensional space. And then we're asking the algorithm to find interesting ways, or the most efficient ways, to find similarities between those observations and to cluster them. So the algorithm tells us that there are 14 distinct clusters, and of those 14 clusters, there are 5 clusters in particular which also have an elevated time to treatment initiation, or a delayed time to treatment initiation. So if we take a closer look into those 5 clusters, we see that those 5 clusters have an average time to treatment initiation that's anywhere between 15 to 30 days longer than average. And then if you look at the different characteristics that define those clusters, that's where we derive our phenotypes. So our first phenotype is defined, and how I've put them up on the slide is the characteristics in blue are those individual level factors which comprise the phenotype, and then the text in green are those contextual level variables which comprise the phenotype. So for our first phenotype, we see that that phenotype is comprised of individuals who are of Hispanic ethnicity, who are young, relatively young at the age of diagnosis, who are on Medicaid insurance. They live in areas with high residential mobility and also a high rental burden, so the percentage of your gross income that's dedicated to rent. We can see that, at least intuitively, this makes sense. Phenotypes 2 and 3 are defined by individuals who are of African American race. They're not married in both instances of the phenotype. But we also see a lot of factors which are markers for disadvantage. So in phenotype 2, we see that those individuals live in communities with high residential mobility. They don't have access to a household car. There's a high number of vacant units within those communities and a high employment rate. For the contextual factors that comprise phenotype 3, we see that overall the median household income is low and there's a high rental burden. So I think phenotypes 1, 2, and 3 kind of make intuitive sense. We see that there's a lot of kind of combinations of markers of disadvantage that are adding up to comprise this phenotype, which is associated with delayed time to treatment initiation. But I think the really interesting story begins from phenotypes 4 and 5. So phenotype 4 is again comprised of individuals who are African American, are relatively young at the age of diagnosis, have private insurance, And then at the contextual level, they live in communities with a higher than average median income. And then phenotype 5 is very similar in the sense that they're comprised of individuals that are African American, they're married, they have private insurance, and they, at the contextual level, live in communities with a higher than average median income. And I think this is really where the interesting story begins. Because people in phenotype 5 have a lot of markers for advantage rather than disadvantage, right? In the context of cancer care, marital status is important in that a spouse who can shepherd you through the treatment process or nag you through the treatment process, that's beneficial. They have private insurance. Typically, when you look at the literature, this is kind of painting with very broad strokes, but we think that private insurance is typically a marker of advantage versus having public insurance. And again, at the contextual level, these are the individuals. These individuals live in communities with a higher than average median income, and yet phenotype 5 is still associated with poor cancer treatment outcomes. So what we can infer from this is that there is some sort of structural factor as it relates to race that's really driving these poor outcomes within this phenotype. So we think that's a really interesting study. So both the Weichuan study and this study that I'm presenting, again, is to really illustrate the incredible research utility of this data infrastructure. Again, because we have geographic information available and the addresses of individual patients, you can do really exciting GIS-based studies like Weichuan showed. Or because we have so much contextual data, you can do studies that really start to integrate the role of place within cancer disparities, like the study I showed. And there are so many other studies that we think that could be implemented using this data resource. So again, we're all ears when it comes to ideas that you might have for conducting future studies using this data resource. So again, just to summarize, NeoCase is a multi-level data infrastructure that can advance both community health and advocacy efforts and facilitate innovative cancer disparities research. So obviously, personally, our team has invested a lot of time and effort into NeoCase. So we personally hold the opinion that it's perfect and flawless, but certainly it's important to acknowledge some of the challenges and weaknesses of this data infrastructure. One of the main challenges is the fact that we are integrating data sources that come from a lot of different places, and they are either at the individual level or they can be at the contextual level. So finding a way to harmonize these data sets is one of the main challenges of this project. Again, in our contextual data, for those data, some of those data apply to different geographies. Some of those data capture constructs at the Census Tract levels. Others capture constructs at the county level. So finding a way to integrate those data sources is a challenge. There's also a challenge of being able to integrate data sets temporally, because the sampling periods for these different data sets vary. Another concern that we have is around the timeliness of the data we get from the OCUS. And this is actually true for most cancer registries. There's a delay between when the cancer case is actually reported to the data registry and then when researchers have access to this data. So currently the OCUS is about 4 years behind, so 3 to 4 years behind. So we're analyzing the 2015 data. We just got the 2016 data a couple of months ago. So there's this lag between when the data is available to us as researchers and when it's actually reported to the OCUS. And this might be relevant in particular to communities with high disadvantage, because we know that those are also the communities with a lot of residential mobility. So it's important to be able to capture those statistics in a timely manner to be able to, because those communities are those that, again, are very mobile. So it's best if the data kind of follows the people. The last challenge that we're really working through is around the governance and data access. So again, this is a very rich data source, which is a double-edged sword in the sense that it allows us to do a lot of interesting things, both from a research perspective, but also, again, to inform community advocacy efforts and outreach efforts. But the other end of that is that there's a lot of protected health information in there, and our key priority is to maintain the privacy of the individuals that are captured within the OCUS. So we're really working closely with the OCUS. We're working closely within ourselves to develop algorithms, at least for the interface, which will suppress low cell counts. to make sure, again, that we're maintaining that privacy. So it'll be quite some time until we're ready to have a website that's www.neocase.com, where people would be able to run these queries on their own, because, again, we're really, really working diligently, and we really want to get this right to make sure that we're maintaining the privacy of these individual patient records. For the time being, for community advocates, for public health officials, for those individuals who want to access our NeoCase data, that's going to be a process where they'll have to work closely with our team, again, so to make sure that they have the proper credentials and to make sure that they're leveraging the resource in a way that's most appropriate to their use. So that's something that we're really definitely working very hard on, to make sure that we get the governance correct around this data infrastructure, and to make sure that we get the privacy and the safety of this data correct. With that, I'm going to turn it over back to Siran, and she's going to tell us a little bit more about where we envision NeoCase going in the years to come.
None of this would have happened without the diligence of Uriel and Weichuan, and then the ICB folks. We worked really hand in hand to make this happen. It was a really wonderful project to work on. So hopefully you agree with us that NeoCase is a really useful tool, and would like to make it as useful as possible to all of you. But I think that there's a lot of room for us to expand NeoCase to an extent where we can also answer a lot of other questions. And so we, Johnny and I sat down and we said, well, we actually asked NeoCase, what do you want to be when you grow up? And this is kind of the vision that emerged. And I see in the audience Sarah marked as well, who was also part of these discussions. But what we would like to do, and this is NeoCase actually, it says here OCIS integrated with publicly available databases, and that's NeoCase. But we would really like to be able to incorporate a lot of other databases as well, such that we would be able to get what we call a 360-degree view of a cancer patient. What is happening to cancer patients? So if we bring in, for example, electronic health records, we bring in administrative claims database, we bring in some other smaller studies databases as well, or the breast and cervical cancer early detection program, or data from biospecimen, genomic data. I think that would give us a much fuller picture of what's happening with cancer patients. So, for example, with the OCIS, there's an important detail that I think we should mention as well, is that Ohio is not part of the SEER program. So the SEER encompasses 26% of the population, and it is in select geographical areas. Ohio is not one of them. And so what we would like to do is create a data infrastructure that mirrors the SEER Medicare infrastructure, because SEER has been linked with Medicare data. And so that is why you see here the administrative database being a really important part of the OCIS. And so half of our cancer population approximately is 65 years of age or older, and so bringing in Medicare data is the most logical step at this point. We would like to, as I mentioned, also bring in electronic health records, so not everyone will be in the Medicare database, and we would like to be able to also capture the experience of other patients, be it privately insured or the uninsured, more importantly as well, Medicaid insured, etc. So our vision really is to be able to go to an investigator, let's say here, let's say that one of you is running a patient navigation program, and come to you and say, would you be able to share your data with us so that we can incorporate it with NeoCase, and also see whether their data would also match with Medicare, maybe with the breast and cervical cancer program, or whichever data we can find that this particular patient in this cancer navigation program would match with, and be able to gather data in that way. So this is the vision we have. So another one is family registry for people with Lynch syndrome. I know that some people in Cleveland do have access to this registry. Can we link that with NeoCase and be able to really kind of see who is getting diagnosed with Lynch syndrome? You know, can we identify these people in any of the other data sets, etc. So I know that this is a little bit of a pie in the sky, but that's the vision we are working towards. However, what we did is, I think that this particular infrastructure is not out of reach even in the near future. And this is a diagram that we put in a grant application that's under review right now, and we called it the OC- Ohio Cancer Data Sharing Infrastructure. So here, the Ohio Cancer Incidence Surveillance System, the OCIS, is at the heart of this infrastructure. And it's been linked with all these contextual data through NeoCase, as Uriel and Weichuan showed you. But we would also like to bring in all of these other data sets in yellow, and also genomic data. And we're in the process of working through a lot of the data users agreements and so on. And plus, we had a very nice institutional support to acquire Medicare data, which is a big chunk of change, I should say. And then we should be able to really get at least, come to here with, in terms of individual level data with healthcare utilization. We should be able to get the Ohio Breast and Cervical Cancer Early Detection Program, which is a screening program for low-income, underinsured, or uninsured women for breast and cervical cancer screening. And for electronic health records, we have received a lot of support from people we have spoken with. I think there is a thirst in people to see systems like this being developed and being deployed and used extensively. And so when we were putting this grant application together, I reached out to 16 different individuals to get letters of support. Not one person turned me down, including from an institution that's in Central Ohio. So I'm really encouraged by that, and I'm hoping that this is a vision that we will be able to materialize at some point. The other part here is the genomic data. So as I mentioned, I've been collaborating with Sarah Mark and Fred Schumacher, who do have access to some genomic data through university hospitals, and we're trying to work out agreements so that we will be able to bring in genomic data into the mix of data. Now, we're not going to have genomic data on every single individual in NeoCase, but we will be able to have it for subsets of the population, and hopefully this will grow over time. There are systems that were very inspiring to us. One is called One Florida. So the One Florida system has been in place for a while, and there are many institutions contributing electronic health records and other bio data to their system. And if that's worked over there, it should hopefully it should work over here too. There's also the system out in North Carolina, Chapel Hill, and they've also really brought a lot of these data together to do cancer-related research. So this is our vision for when NeoCase grows up, and we would like to really cater to your needs. Please keep the dialogue open. Just a couple of days ago, one of our collaborators stopped me in the hallway and she said, "Do you have environmental data?" So people in Chicago found an association between arsenic and prostate cancer. Would you be able to do that for breast cancer in Cleveland? And so we'll be getting environmental data as well to bring into NeoCase. So one of you might have a very different idea about some database, please let us know. We would like to be as responsive to your needs as possible. That's part of that's our mission for population cancer analytics. And Kurt is here, and I'm sure he agrees. And so, with that, I will open to questions.
Can you just clarify the timing? I know you're in data and you mentioned a little bit of what you're trying to go, but what is the timeline for
So,
making this available?
for NeoCase, so the beta version pertains more to the interactive system than to the system that we currently have access to. Right now we have access, the NeoCase is present, is physically there. We can go in and then run any queries that we would like. Let's say that you're interested in putting together a grant application or doing some outreach effort, and then you can come to us and say, now, where are these cases clustered? And we should be able to give that to you. The beta version is for people to be able to access the interactive system and run queries themselves. We're not there yet. And I think that the greatest impediment is, as Uriel mentioned, the small cell situation. And that's very sensitive. In our data users agreements with OCIS, we have specified that we would not be releasing any cells less than 11. And that goes across the board for all of the databases. And so it makes us feel a bit nervous to say, yeah, if the system is out, you can just query to your heart's content. Hopefully we'll be at a point where we should be able to do that. But until then, you can just come to us, and we should be able to help you out with that. But we are hoping that for people who are active in community outreach programs and saying, I would really like to know where these clusters are. Can you give us some guidance? We're hoping to be able to start working with them ASAP.
American Cancer Society represents.
Oh, great. Yes. Thanks for coming. And yes, Kurt.
What does the analysis look like that leads to an area being identified as a cluster?
So we're using spatial analysis. One of the methods we're using is SAT-scan, which is a method to kind of give you, for lack of a better term, a blip, or to show you the cluster when the average in that geographic area is higher or lower for cold spots for a certain outcome that you're looking for.
So it's just the rate, just statistically.
Yeah, it could be rates, yes. For the most part, it is rates.
Is it comparing to the rate in neighboring?
In the surrounding areas, yes.
Okay, not to what is expected in that particular county, based on the age, sex distribution.
Well, I think that by looking at the surrounding areas, it looks at all that distribution and then it factors that in. Yeah, SAT-scan is fairly sophisticated in that way.
And that's what Uriel showed us. He showed us when you compare to the state versus the county. So you can change the comparator.
Oh yeah, you can change the parameters as you wish, and then produce a map as well. So right now, our focus thus far has been on the catchment area, because the Case Comprehensive Cancer Center is an NCI designated cancer center, and we have a mission to really be responsive to our community's need, and our catchment area includes the 15 counties in Northeast Ohio. But we will be able to do this statewide as well. Yeah, Sarah.
In the K-means or
K-medios. Yeah.
How sensitive is that to changing? How sensitive are the clusters to changing parameters of the cluster, of what you put into, how you define your clusters?
Yeah,
How
so
sensitive is it?
definitely the stability is something that you have to be cautious of. So before you feed into the model, I think it's important to vet the variables that you put in. Just because it's a machine learning algorithm doesn't mean that it's smart enough to figure out whether or not variables are good or bad.
Yeah.
So there's a lot of kind of, there's a conceptual framework that you need to develop around the variables that you're inputting into the model. It isn't very useful to know, put in like atmospheric data if it's warm or cold, right? You need to input in variables that are relevant to the outcome that you are expecting. And also, once you've decided which variables to include, the stability of the clusters, those are determined by different parameters, right? So you just want to optimize the clusters that minimize the distance within observations within a cluster, and then maximize distance between clusters. So that part of it, I think, is a little bit more stable. But definitely, when you're inputting in the variables, that's where a lot of attention needs to be put in to make sure that the variables that you put in fit into some sort of conceptual model that you have in your head.
Did you put any parameters on is there any p-value associated with what becomes a cluster and what doesn't?
Not a p-value, it would just be a measure of distance, so it would spit out a number. So if you have 5 clusters, the average distance between clusters is this, versus if you have 4, you have this distance. So you want to optimize, again, the distance between clusters, make that as large as possible, and then the distance within observations in those clusters to be as small as possible.
Uriel,
To guarantee discreteness of the clusters.
Yeah.
would this be similar to cart analysis? So in cart analysis, we know that the trees that we produce, the classification and regression tree, sometimes can change very quickly according to the parameter that you specify. And so we tend to also produce random forests, which does a lot of bootstrapping in the background. And so you would compare the variables. And would you do random forest here too?
Yeah, I think definitely, using different methods which create similar outcomes, and then comparing the outputs across methods, I think, is a really good sanity check and a good validity check. So we have run cart models, we have run random forest models on this data, just to see which outputs are the most interpretable, and also to make sure that they're consistent across models.
So I think that this is a great platform that can help bridge the gap between community and researchers. So I guess one question is the pie in the sky idea, that long term, do you foresee there being institutional support when community members or organizations come and say, we put this in, can you help us make sense of it?
Yeah.
What does this mean type of?
Yeah, that's a great question. I think that this especially, so let me step back. There are databases here, especially, for example, this one, Medicare data and OCIS and Ohio VCCP. So these are data that you get access from the Ohio Department of Health or CMS, and people from the community are not involved in that. But for this kind of vision, I think that you need the full engagement of people from the community and from the researchers who are going to contribute data to you. And the one very important feature of all this is going to be the data governance structure. If you don't know, if you can't tell people how you're going to receive their data, to do the linkage, to then distribute the data. And the question is, for example, if I'm asking for these data, some researcher is doing some navigation program, and we have received the subset D and we've linked with everybody. So are we then going to share the data only with that researcher or with other people who may be just as interested in the outcomes, for example? But coming back to this one, which is a lot more accessible at this point at least, I think that this is a great place to start with data governance steps. And we did include a specific aim just to start the process of discussion. What does this mean? What are your reservations, and what are the circumstances under which you would decide to share data with us? Maybe the researcher doesn't feel comfortable sharing data with me or my team, but they would be interested or more comfortable sharing the data with an honest broker who is going to do the linkage but doesn't know where the data is, so things like that. I think there's a lot to work out, but without a data governance structure, it's not going to happen. And we need to really gain a very good understanding as to what people are expecting, what they would like to see, what is their, what are the circumstances under which they would feel more comfortable sharing the data and all that thing. So, yeah, Lillian.
That's what I was going to segue. Because I was going to ask, how do you determine which data sets, like these are national data sets that you're feeding that you're using here, but how do you determine, let's say if I had, I was a director of a center and I said, oh, I've heard about your project, I want to contribute my data. So do you have minimum criteria that you set to say this is the data that we'll include in this type of project?
Well, I mean, we haven't thought that far as to what exactly you would like the data to be as with high integrity. Of course. We haven't determined the criteria to say, yes, this is high integrity data. I don't think we have really come this far to be able to say, well, yes, if this particular researcher would like to share with us their patient navigation data, these are the criteria I would like to set to make sure that the data integrity is A-OK, and then we bring it in. But these are things that need to be worked out in the data governance. That's going to be really, really important.
Because the only reason I asked is Dr. Modlin, Charles Modlin of Cleveland Clinic. I know they're developing, he's helping to develop the African American, I think it's the
Men's Health.
Well, he's the director of the Minority Men's Health Center there. But I know they're developing the African American, basically a data repository. So because your focus is on health disparities, that's what I was just wondering, with something like that, be able to be a partner and implement with that type of data.
Absolutely. Right. Well, we need to learn more, and we need to know exactly how the data were collected and all that. Thank you.
This is so fascinating. It really is. It's exciting. Where you are is exciting. Where you're headed is exciting. We probably have time for maybe one more question, if there is one. More questions may come up as you go along.
Please reach out to us. Uriel, do we have an email here somewhere?
We do not.
We do not. But
figure around if you want our contact information, I guess.
Yeah. So, thank you. Thank you all very much.
Just to remind everyone, all of our sessions are videotaped, so if you want to watch this one again or see any of the past seminars, you can go to our website at prchn.org. And we can probably, if you contact us, we can also give you contact information for the team. So thank you all. And thank